We're going to switch gears a little bit and talk about a topic near and dear to my heart, which most people would think is crazy and sadistic, Medicare reimbursement. But there's been some changes that happened at the end of 2020, and at least on the PN side, not so much EN, there's been some changes. So I love this doctor's face because he's like, I don't know what that means. I don't know what you're talking about. That's what his look on his face means. And that's, generally what most of us have thought about Medicare reimbursement for many years. So let me move to the next. Now I'm going to freeze up and it won't let me. There we go. My disclosures, I work for a national home infusion provider and I volunteer for FASPEN Public Policy, where I've had the delight of serving as the chairperson for the last couple of years. Here's what we're going to talk about today, and we'll buzz through this pretty briefly. The history of CMS coverage for home PN and EN under the prosthetic device benefit. We're not going to spend much time on that, but for those of you that haven't had to deal with Medicare and their coverage rules, it'll just give you a little bit of a flavor for how complicated that can get. What were the limitations to the old policies? And then understanding now that some things have changed, what do we need compared to what we used to need a long time ago to assure that all of you have the coverage that you deserve under Medicare or CMS? And then we'll talk a little bit about the collaborative efforts that Oley, FASPEN, the National Home Infusion Association, and numerous other groups have collaborated on for the last few years, knowing that these laws, particularly under Medicare, were not and are not sufficient, and they don't follow the same rules that the rest of the payer communities out there follow. So how do we all work together to fix that, to make it better? So just a little quickie snapshot, the history of Medicare, or the acronym sometimes you'll hear used, CNSC stands for the Centers for Medicare and Medicaid Services. And the acronym that the government uses actually for parenteral and enteral nutrition is PEN, or PEN coverage. Believe it or not, these rules were started in 1984. I'd be willing to bet we have some folks on the call that weren't even born then. So this was the original law that came out from CMS talking about when parenteral and enteral nutrition would be paid for by the federal government. Back at that time, they put this under what they called the prosthetic device benefit, thinking of like a prosthesis. Think about like if you had a prosthetic leg that's taking the place of your leg, this is how CMS or Medicare views enteral nutrition and parenteral nutrition. So the tube or the pump, if you're on enteral therapy, is serving as the prosthesis for your stomach or any function of your swallowing mechanism or your stomach, meaning it's broken, it's not going to get fixed anytime soon. So this is like a prosthesis. If you were talking about parenteral nutrition, it's basically your small intestine and the pump. So it's like taking the place of something that's not working or broken, and it's not going to get fixed anytime soon. This coverage criteria, the bulk of it, everything about it, has not been updated since 1984. So where are we going on? 37 years now. When we think about that prosthetic device benefit, the issue of permanence is the crux of this, and this still holds true today. And when I said there were some changes that went through at the end of 2020, this permanence issue still holds because the benefits for both PN and EN still today are going to fall under the prosthetic device benefit until someday that we can change it. Part of what we need for documentation as a provider, whether a home infusion company, the physician, your healthcare team, we need a document that spells out by your attending physician, and this is the language of the government, that this length of need, how long are you going to need home, parenteral, or enteral therapy? It needs to be written in the medical record before you come home to the hospital. And the government requires that it's got to be what they call indefinite or long duration, meaning at least 3 months. And that's been the same since 1984. It's not saying that your condition won't improve. It can improve, but it can't improve under 3 months. So for people that, let's say they have a condition like pancreatitis, or perhaps they have a cancer diagnosis and they're undergoing chemotherapy or radiation therapy, and they do need parenteral nutrition, or enteral nutrition, whatever the case may be. If you only needed it for 6 weeks, 8 weeks, 2 weeks until you go back in to have surgery, you would not have coverage. So it can improve, but it's pretty much got to be not after, way after the 3-month mark. And anything that's temporary is just simply not covered. When we talk about enteral or tube feeding, this is some of the language, and I don't want to read the whole thing to bore you, but basically, this language is what stands today. It gets confusing within the government, just like medicine, where there's so many different acronyms that are being thrown around. So instead of me saying every single slide, national coverage determination or local coverage determination, we'll use the acronym NCD. That is really the overarching crux of the policy, crux of coverage if you're a Medicare beneficiary. So what they're saying, and this spells it out in their language, enteral therapy is covered for a permanent non-function or a disease of the structures that normally permit food to reach or be absorbed from the small bowel. And you need tube feeding to provide sufficient nutrients to maintain weight and strength commensurate with overall patient status. When I started in home care, it was probably in the late 80s. Back then, I think they used to have a calorie range. They did away with that after a few years. So right now, the rules are much more detailed than just this. The rules will actually spell out what calorie range you need to get. For enteral, it's units of formula, it's grams of protein, et cetera, et cetera. But this is the overall, main function of the policy is saying you need enteral. You can eat some food, but you're not going to eat enough to get what you need. So the enteral needs to be the main source of your nutrition. You have to have something that's broken, either in your mouth, your swallowing mechanism, cancer, a tumor, Parkinson's disease, Lou Gehrig's disorder, anything like that that's a permanent condition. And there's absolutely no coverage whatsoever for oral supplements or a short-term tube feeding. And that's the gist of where we are today. When you think about parenteral or IV nutrition, same type of prosthetic device benefit mentality, covered for permanent severe pathology. And here's something funny. I'm writing an update on this policies for a GI journal, and the editor came back to me and crossed out alimentary tract because she's a well-known dietitian. And I had to write back to her like, no, Carol, we need to keep it as alimentary tract because that's what it says in the policy. It's kind of an old school term you don't hear so much anymore. Basically means GI tract, your gastrointestinal tract. But same concept, your small intestine isn't working. It's not allowing the absorption of sufficient nutrients. So you need IV therapy, IV nutrition in order to maintain your weight and strength commensurate with your general condition. So that remains today since 1984. That's the way the government looks at this. So what has happened, I'll tell you in a minute. Like, we've been fighting obviously about this, not fighting, but fighting for changing it for decades. Where we're at today after the changes that occurred last year, we have more fight to do because that issue of permanence remains until we can change this. And what sometimes people don't realize is that the Medicare policies, it's not like Blue Cross or United or Aetna or any other insurance company where you literally could call them up and say, hey, your policy is this, but I have a patient, or I am a consumer and this is my situation. I'm asking if you consider, making a change or an exception to this. When you're dealing with the federal government, this is law. So it literally will take an act of Congress to change this. And that's why things take so much longer to enact change. Medicare as an insurance company, they're really not an insurance company. It's just different than dealing with any other kind of payer. That functional impairment language is still here, whether you're talking EN or PN. All right, this is just to show you, this is an old checklist of what the old policy for PN was. Look at how long and teeny tiny the print was. Those of you that may have Medicare as your primary insurance, if you've had it for a while, and you might remember when you came out of the hospital, all the different tests and studies, and it might have taken a little bit longer to get discharged because we literally had to go through all of this and say, did you do this study? Did you run that test? What are the results? Oh, that doesn't meet it. We got to do it again. Do we do the INOs? It was a very long, detailed, and frustrating process for everyone. So that just shows you one example of a typical checklist that a lot of the companies and physicians would utilize to try to figure out if indeed someone had coverage, home coverage for their PN. Here's another way to visualize it. And this is this flow tree or decision tree. This has been around, I think, since I started in home care, seriously. And it was published every couple of years. I think the National Home Infusion Association put this out there, but it was a way to try to get through the weeds of understanding what that convoluted policy was. So some of the barriers, obviously with that old history, these national coverage determinations, and then they broke it down into more nitty-gritty rules, and they called that local coverage determinations for, lack of explaining it. It's just more minutia, more rules, more ways to get around paying for it, quite honestly. At least that's my opinion after 30-something years in home care. So these hadn't been updated. A lot of the studies and tests and diagnoses and so forth have changed over time. We don't practice some of PN, home enteral is the same, of course, but you all know there's new tests that come out. We've heard some of that yesterday and today. We might use PN today for a diagnosis that, in 1984, you didn't use PN, maybe like a bariatric surgery. Bariatric surgery existed, or weight loss surgery, but we didn't really use TPN for it back then. But now we might if someone has complications. So things have changed a bit. And not all patients need long-term nutrition support. There are some folks out there, maybe not so many on this call, but there are some that might need PN for 6 weeks, 8 weeks, maybe just until they're done with their chemotherapy regimen. And unfortunately, those patients today do not have coverage for home parental nutrition. The PN LCD, or the policy, was really, think about 1984, home care was just getting going. It was not very common at all. And when PN was first invented, that's back to the 1960s, late 60s actually, pretty much the only use for PN was congenital GI long-term diagnoses, like perhaps Crohn's, or babies that were born with congenital things like gastroschisis, Hirschsprung's, whatever. We didn't really use it for oncology, hardly at all. So those types of things weren't taken into consideration back then. So where did that leave people? Either staying in the hospital, going to a skilled nursing facility, or LTAC, which is a higher cost of care setting today if they didn't meet criteria, or, believe it or not, some patients pay for it themselves, which is cost prohibitive for most people. So these are just limited options showing this is why, we battled to get this to change for so many years. So I'm just putting this up to show you that over the last 2 decades, maybe even 25 years in total, we've been lobbying and working together to go to the government and say, hey, how about let's get rid of that length of need thing? That's really, not everybody needs PN or EN for the long term. Hey, can we get rid of some of these studies that hospitals don't even do anymore, like measuring the amount of fat in your stool, doing a 3-day, 72-hour fecal fat test? There have been numerous going back to the government. Let's write a letter. Let's file a reconsideration. And really, pretty much, it's fallen upon deaf ears until 2020. So there have been changes within the government that now, because of online, social media, things are definitely much more transparent. So if you file a reconsideration, or you put a request in, or you ask for a live hearing, someone was speaking to that in regards to the FDA, I think earlier on some of the sessions, they have to be transparent now. They have to respond to you. They can't just blow you off and send you a letter like the government used to do with FASPEN and just say, sorry, these rules are fine. We're not going to change them. So finally, learning like, there's a whole new process. And there's some new medical directors, quite honestly, at CMS let's get together again. Let's pull some people together, create a subcommittee, and let's do some research. That way we're giving them evidence-based medicine to say, this test isn't even done anymore. Why do we need to have this? This is, more harm than good for the consumer or the beneficiary. Why would we still force a failed tube feeding trial? So we got together, we pulled that together, we asked for a meeting, and we got together with them in July 2020 of last year, meaning me, a representative of FASPEN, and a representative from the National Home Infusion Association. We had Joan and everybody's input along with us. And miracle of miracles, they made a change. And I don't think any of us saw this coming, quite honestly, because after 30 years, we were pretty downtrodden and feeling like, all right, we'll give it another try. So on October 8th, we waited a couple months. They came back and said, you know what? We're going to retire those local coverage determinations. And remember, I said those were the documents that had a lot of the minutia and the nitty gritty of all those tests and that flow chart with all the crazy things. They basically just said, we're throwing that all out. And we're going to throw the enteral one out too, effective November 12th, 2020. And this was the language they used: evolution of parental nutrition clinical paradigms. We didn't ask for them to throw it out. We simply figured, you know what, if we go and ask for some changes, can we have this test instead of that test? Not even thinking, but our sense was that they probably thought everything that we asked for, and they did keep asking for more references, was that they were listening and it was going to be too much work to go back and change this or that and that and that. They just threw the whole thing out and figured, okay, we'll just start from scratch and see what we need to do. So those LCDs for both parenteral and enteral nutrition, and again, this is just Medicare, straight Medicare, not the new like Medicare Advantage plans or Medicare replacement plans that you can sign up for, during open enrollment. Things like, oh, my Blue Cross has a Medicare plan, my Humana has a Medicare plan. This doesn't really pertain to that at all. This is straight Medicare. You opted and chose straight Medicare, not another type of plan. So as of November 12th, those went away. They came out with some new documents. There's a link here in the PowerPoint. We'll get that out if you want to see the minutia of detail. It has all the codes and things for the B codes for both enteral, parenteral. But in actuality, what we were left with, we kind of went from 0 to 360, or the opposite. We had 1 million rules and regulations. And now where we stand today is we've got kind of a loosey-goosey compared to what we used to have, where it's like, all right, it has to be permanent and you have to have a functional impairment. And it depends what you're talking about for enteral or parenteral. So, they're using language like reasonable and necessary, which is a breath of fresh air, because what we had before was definitely not reasonable and necessary. But that's what we're back to now. We have a lot of the same paperwork, documentation, when you sign for deliveries, proof of deliveries, standard written orders, it's the government. So there's, I'm exaggerating, but 1 million pieces of paper, and that's, not really an exaggeration, but, we still have the rules of the nutrients. Your calories have to be in a certain range. The protein needs to be in a certain range. If you're on PN, the amount of fat or lipid is spelled out. And those are some of the things we're waiting on. Over the summer, we all put in recommendations, and they are going to come out with some new local coverage determinations or rules with some of this specific detail. And we lobbied hard to say, please, do we not need to get all this extra documentation? Can you just take it from the order that, yes, if it says the patient needs this to sustain life, then we would assume that their PN or their EN is going to give them enough calories, protein, and lipid, and there are exceptions to the rule. So we're still hanging out waiting for that, but the rules for pumps and supplies and all of that pretty much is going to stay the same. The forms, the codings, the HCPCS, that's all stays the same, but we're waiting for the final. So again, not to bore you, this is This is the actual language of the National Coverage Determination, which is all we've got today. So again, it says it's got to be reasonable and necessary. We're still fighting the point. I know a lot of you that daily might be jumping out at you because many consumers or patients that have short bowel syndrome, sometimes you only infuse 5 days a week or 6 days a week or 4 days a week, but you still need it. But you might not need it 7 days a week. So these are the kinds of nuances that keep in mind. This is 1984 that this was written, and we're trying to negotiate with them. And we're just figuring if we put in the extra language that explains why you're on 4 days a week, why you're on 5 days a week, not 7, that we'll fight that fight. So in any event, some stuff remains the same, some stuff is different. So this is just to show you a couple of examples where in the old days, meaning prior to November 12th, these types of scenarios, the beneficiary did not have coverage. So, in the past, let's say you had short bowel syndrome, you've had it for a long time. If we didn't have your operative report to prove how many feet you had left, they wouldn't take it. Now, if your medical record says Penny Allen has, 3 feet of small bowel, she's been on parenteral nutrition for 10 years, and you're switching to Medicare, we can use that now, and we never could before. We had to search for old records, and sometimes we found them, and sometimes we didn't. In the cancer realm, in the past, pretty much almost anyone with cancer that was on parenteral nutrition almost didn't have a prayer for having coverage under Medicare. You needed to have a complete bowel obstruction if it was something like ovarian cancer or GI cancers. Now, again, you need the functional impairment saying, hey, this GI tract is not absorbing nutrition for XYZ reasons, and we think it's going to be for like the next 6 months, then you'd have coverage. Same thing with that bariatric surgery I mentioned before. In the past, almost anyone that had complications from bariatric surgery, it was really difficult to qualify that with the old rules. And now many times we can. So is it perfect? No. Is it better? Yes. So here's that reasonable and necessary language. We still have this today for enteral therapy. And again, it's got to be, think about that prosthesis, and that's really the basis of this. Until we can move PN and EN out of that benefit and Medicare comes up with some kind of reasonable home infusion benefit, this is what we're stuck with. So, and these are two scenarios, again, where enteral would be covered. Enteral really didn't change a lot. What we are waiting for and what we fought for was the mandate, almost like step therapy, if you've heard of that, if you've gone to Digestive Disease Week, when you say you have to try this kind of formula first before you can go to that formula. That's what we're pushing back on. We don't have the new policy yet, but other than that, in the enteral world, almost everything stayed pretty much the same with this round of changes back in November. So we'll see what they come out with. We're hoping for the final policies to be out, anyone's guess, this summer, early fall is what we're saying. So here's the most important part of this, I think. What does this really mean for you? What does this mean for your physician, for your company, but more importantly to you? In the past, there's been a number of abstracts, articles. There was a poster at FASPEN this year, once again showing that very few people met criteria for home parental nutrition under Medicare. So that's been held up for a couple of decades. It's been historically 10 to 12% of Medicare PN referrals. So that was awful. That's why this was so near and dear to my heart. Now, my company, which is a national company, we've been tracking, compared from November moving forward, how many people are meeting criteria now. As I said, it's not perfect. It's not 100% because of those people that maybe they only need it for the shorter amount of time. They're still not going to qualify, but we are seeing that now 65 to 70% of our Medicare PN referrals are now meeting criteria, which is a tremendously better situation. It's going to be a lot easier for us to qualify a beneficiary who maybe you had Blue Cross and now your disability came through. So you now have Medicare as your primary payer, or you turn 65. maybe you were working, you had a Humana policy or an Aetna policy, and you were on PN, and they had easier rules, like, hey, you need PN? Yes, of course it's covered. Medicare, that was never the case. And we had a devil of a time if all of a sudden someone flipped to Medicare July 1 and we were like, oh no, we don't have the documentation that we need to qualify you. And there was no grandfathering in or anything. So some of you may have gone through this, and it was awful. This will be easier now to be able to, have your physician document fully based on your medical record that something is broken. It's not going to be fixed anytime soon, and you're going to need PN for X amount of time. So it should save us time at the discharge, much less time to review records to say yay or nay, rather than saying, can you do a fecal fat study? Can you do an I&O? Can you do another CAT scan or whatever to see if the bowel obstruction is complete or partial? A major point, I think I've driven it home. If you need PN or EN for less than 90 days, it's still not going to be covered. And the other bad parts are that other therapies, we're still in the same boat, like hydration. Many of you with short bowel and other conditions that need additional hydration, IV antibiotics every once in a while, that is still not covered under straight Medicare. There are some workarounds, and there are things that we do to be creative to try to get it covered for you. But surprisingly in 2021, there's still, no coverage for that, which is crazy. So that means we're like Sisyphus in Greek mythology. We're pushing that big rock up the hill, and sometimes it rolls back down on us, but we're going to keep getting up and keep pushing the ball up the hill to see if in the future, we work towards getting that out of the prosthetic device benefit, trying to get coverage for those who need PN or EN for a shorter amount of time, and then the other infusion therapies that should be covered but aren't under Medicare. And again, we're hoping for the final to come down from the government.